Great. Thank you all for joining us for another exciting webinar with NYP, New York Presbyterian Hospital, and the KidsHeart Medical Center. It's one part of the series that we've been doing for an educational outreach to our colleagues in the United Arab Emirates. And as usual, we have great panelists with us, and we have Dr. Sulaiman and Dr. Aouda from the KidsHeart Medical Center. We're very proud to be part of the affiliation with them. It's been a great relationship for many years, and we hope that we'll be able to provide more insight into the collaboration with us over the years. Without any ado, trying to get moving forward, Dr. Sulaiman will introduce the panelists, and we'll go on from there. Thank you.
Thank you, Mr. Assam. Thank you to our audience, and thank you to our speakers and moderators for being here tonight. It's another exciting night. I hope we will have a good lectures, which I am going to do one of them anyway. So I will start with introducing our moderators, Dr. Hussam Aouda, my boss, and he's our CEO at the Heart Medical Center and the KidsHeart Medical Center. And he's an adult cardiologist who is doing intervention. He's a pioneer in cardiac intervention, work in Cleveland Clinic as well as in the Heart Medical Center as well. So that's Dr. Hussam Aouda. The next moderator is going to be Dr. Michailidis. Dr. Michailidis is one of the pioneers in fetal medicine in this country. He has established his practice for so many years, and he has served so many patients with fetal anomalies. And we are very happy that he will join us as well. I will give the microphone right now to Dr. Hussam Aouda to start introducing our speakers. Thank you to everyone.
Just a second, Doctor. I just want to inform everybody that we have the chat, the Q&A session open at the bottom. So anybody who has any questions regarding any of the panelists and the lectures, please post it, and we'll try to address them either during at the end of the lecture or at the end of the webinar.
One more thing before we move. All the questions for the speakers will be in the end of the session. So we'll finish all the lectures, and then we'll move on with the question and answer. Thank you very much. Dr. Hussam Aouda.
Good evening, everyone. I'm Hussam Aouda. Thanks, Dr. Sulaiman, for the introduction, and I'm excited to be a part of this webinar. It gives me a great pleasure introducing my colleague and friend and partner, Dr. Sherif Bakir. He's a consultant intervention preventive cardiologist who has been working in Abu Dhabi for over a couple of decades. And he is a leader in the field of preventive cardiology. He has many special interests, including preventive cardiology and smoke cessation. He has an interest in women health and with cardiovascular disease. And he is going to talk to us today about pregnancy with a heart disease. So without further ado, Dr. Bakir.
Thank you very much, Dr. Sam. Now I am sharing my slide. I hope you see it. Okay. I think everybody's seeing my slide, yes?
Yes, we are.
My slide is clear?
Yes, sir, it is.
Everybody can hear me?
Yes, sir, we can.
Okay. When we talk about cardiovascular disease, I will go through the new guidelines published by the European Heart Association in 2018. And the aim of my talk, of course, it's very difficult to cover it in 25 minutes, but I'm trying to explain what is the idea and what we should do. First of all, we have to understand what is the physiology of pregnancy. 30 to 50% increase in cardiac output, stroke volume, and heart rate. This is something we have to understand during pregnancy. Also, we have 40% increase in the blood volume. We are talking about whatever the pregnant lady is a normal lady or lady with heart problems. Also decrease in systemic resistance. This is part of the physiology of the pregnancy. And hypercoagulated state. So this is also part. All why we are saying this, because any cardiac problem or any problem that the pregnant lady have related to any of this will be more exaggerated. Also, the acute change during the labor and delivery itself. So when we are dealing with a pregnant woman, we have to know that we should deal with her before she became pregnant, if she have cardiac problem, during pregnancy, and the time of delivery, because each stage need to be addressed carefully based on what is the cardiac problem she has. So this is a new guideline 2018 European Society of Cardiology about managing cardiovascular disease in pregnancy, which I will go through it. Of course, it's difficult to cover it completely, but just to give the important hint. Pregnancy is complicated by maternal disease. We said it's not too much, but it's around by 1 to 4% of cases. And also we have to know is hypertension is presented 5 to 10%. Knowledge the risk, as we said, during pregnancy or even before pregnancy will help us how to manage these cases. And the number of cases, usually we said, is too small for a physician to be depending on his own, because usually the cardiovascular, if I'm a cardiologist, my cardiovascular expert will be on cardiology, but during pregnant lady, I'm seeing, or the cardiologist seeing not too much of pregnant lady with cardiac disease. So usually you cannot depend on your own experience alone. And the number of prospective study is very limited. Of course, we know why, because of the ethical story. I cannot put the pregnant lady and put her the hazard for new medication or something under experiment. Also, there is risk. We have to know that we have to know the risk. Risk estimation should be individualized. Each patient, her risk is different. Even if they have the same disease, but it can be different. And we have to know that each disease have different risk. Also on the people with a moderate risk or high risk, now the new guideline telling us that we should start to use the WHO risk evaluation, which is the modified WHO, and we'll see through my talk. And also another important part have been added in the guideline is the pregnancy heart team. We cannot depend on one single doctor alone. Of course, it will be based on the how much the lady or how much the risk for the pregnant lady. What we mean by heart pregnancy team, it is cardiologist, obstetrician, anesthesia, genetics, many, they are all of them have to be included. Pulmonologist, if the patient have pulmonary hypertension or lung problem, hematologist, because they are sometimes using the coagulability drugs, or so it is not. And also the pediatric cardiologist is part of the team because he will be involved during the fetal and after the delivery. So it is a pregnancy team. The second thing, we should from the beginning, if the patient became or the lady became pregnant, we have to know the end, which is the delivery plan. How will be ending the pregnancy? This is something should be clear from the beginning. And it should be made exactly between the 20 to 30 weeks, because this is very important and the decision should be very clear for everybody. What is new in the guidelines? What in 2018 compared to 2011? What was the new? Number one, it is, as I said, the modified WHO recommendation have been put it in the core or in the center of the evaluation. This is something very important. Also, upgrade the intervention is recommended before pregnancy is very important. As I said, if a lady have severe mitral stenosis, we have to give the idea or to solve the problem before pregnancy. Don't wait for the pregnancy. But as we know, in the third world country, in many countries, we'll find that we face with the lady already came with pregnant and with the disease. Another important point also that very important have been in the news, that the ladies who need to oral anticoagulant and especially have mitral valve, prosthetic valve, or the patient have to be on oral anticoagulant. What we know and what we added also in the 2018, that if the lady is still using or need to have low dose of warfarin, for example, less than 5 milligram, we have to continue on that. No need to stop it and change it. This is also another important. This is just to show you the modified WHO recommendation or classification. And as we will see, it will be WHO stage 1. This is mean that there is nearly nothing, small or very mild, like pulmonary stenosis mild, patent ductus arteriosus, mitral valve prolapse, things which we are considered as minor things. And then we will have to the modified WHO2, which mean now we'll find that when we go to 2, WH2 or WH2 to 3, WH3 to 4, we are going higher in the severity. And I cannot go through all of them on the same session today, but just to tell you, there are some cases, for example, if you look to WHO 2 to 3, if we talk about the Marfan or the dilated aorta or bicuspid aortic valve with dilated aorta, here the severity start to be more. And we'll find that if you go to the modified WHO4, here we recommend not to have pregnancy, severe mitral stenosis, severe symptomatic aortic stenosis. All these are very critical and have to know that here we have to use the team. And if you go to the risk, you'll find that, as we'll go quickly in this slide, that the risk is increasing, of course, with the modified WHO. And for example, in WHO4, counseling is very important because pregnancy should be contraindicated in these cases. And sometimes you have to discuss about terminating of the pregnancy. So this is very important to put it in our mind. So this slide, to summarize in a very simplified way, that WHO1 is nearly nothing, but when you start from 2 to 3 to 4, here the severity is going down, the severity is increased. So selected revised recommendation, just in time, I will go through some selected. For example, in 2011, Sotalol was the drug of choice, while in 2018, for a patient with having supraventricular arrhythmia, or the fetal himself have arrhythmia, here the flecainide. I think me and Dr. Sulaiman just faced 3 weeks ago in the clinic, one lady with her fetus have supraventricular arrhythmia, fetal echo have been proved that, and the decision was to start in this lady on flecainide, and it had been shown a very good response. So this is part of that what we are changing now. Also, as we said, the low molecular weight heparin is the drug of choice now for prevention of pregnant lady with VTE, or it's recommended also that when we use low molecular weight heparin, if we use it, we have to be based on the body weight, and this is very important. Also, that in pregnant women on low molecular weight heparin or unfractionated heparin, the story is not finished. We have to know that we have to perform weekly anti-factor 10 level. This is very important. Also, we have to understand that caster ablation, for example, if we are in 2018 now, we allow a little bit that we can consider caster ablation during the pregnancy if it is refractory to medication. So now we are a little bit more aggressive. But as we said, this should be considered in expert center. It's not everywhere. Also, the question about the D-dimer. Before in 2011, we are using D-dimer in the imaging if we want to detect the possibility of VTE. But now we said it is in 2018. It is recommended that if you are not able to get the final diagnosis, magnetic resonance phenography should be considered. So now we are a little bit more aggressive in using the modality which we have. Also, very important, the FDA is still warning us, any new medication, anything, we don't have any experience in pregnancy. And as we said, most of the drug experience on pregnancy, it's coming through the accidental use of the drug, and we discover after that that it is safe. But still, this is something should be considered. No trial to use any of the medication which is not accepted, because this is very risky for the fetal and for the lady. As we said, also pregnancy is not recommended in patients, as I'm saying, which we should, and we have to understand that there are certain disease, it is not allowed to be pregnant because of the very, very high risk, up to 40%. The risk for example, when we're talking about the Marfan syndrome with aortic dilatation, bicuspid aortic valve with more than 50 millimeter, this is very important to be considered. and whatever. So this means that this type of ladies, we should follow them before to allow them not to get pregnant. So it is very important that we have to also to write that right heart catheterization can be done for a pulmonary hypertension. This can be performed during pregnancy, but with very, very strict indication. So I'm saying now we are now moving to a little bit more toward some aggressive maneuver, but as we said, in a center, we're able to do this. The treatment dose of low molecular weight heparin is recommended in pregnant patients with chronic thromboembolic pulmonary hypertension. This is class 1C. So this is very important. Another new, what is added new, the thrombolytic to manage patient with pulmonary embolism is only recommended in patient with severe hypotensive or shock. I have an experience 3 years ago, or no, to be honest, 2 years ago, there was a lady had been referred from another hospital to the same hospital where I was working. And the lady was having pulmonary embolism, had been diagnosed, and it was diagnosed completely. But because of some form of hesitation and some form of that, this lady was the question, should we start to use thrombolytic therapy or not? She was impending shock, and actually she went in shock. And there was some decision, and finally, badly, the patient was not thrombolized, and finally she died. So we have to know that the team is very important, that cardiac team, and we have to take the decision. And sometimes it's very difficult decision. But according to the guideline 2018, and we raised this during the discussion with the team, but unlikely there was some contradiction and the family refused, and the patient was not able, we're not able to save her. So thrombolytic therapy should be considered. In women with high risk for thromboembolism, it is recommended to convert low molecular weight heparin to unfractionated. Here is very important, because we know that low molecular weight heparin is very easy to use. Unfractionated, it will be difficult, but sometimes we have to take the difficult decision. So this is also will be part of the heart team. In women at low risk for thromboembolism, on therapeutic low molecular weight heparin, it is indicated for the, to put the plan, what will be, it is cesarean or to be recommended to perform the induction, how we can do it. And also we have to perform that, we have to recommend that to perform 24 hours after the last dose of the low molecular weight heparin. It is recommended to choose the valve prosthesis. This is very important. If you know the lady, while she is in childbearing period, that we have to decide what kind of valve should be done for this lady, because if she are going to be pregnant, it is very important. And this is why we said we should have the heart team, so we can get her before being pregnant if the valve will be there. It's recommended to manage pregnancy in women with mechanical valve in a center that able to deal with. Why? Because as we said, that this is a carry risk. This is a risky patient. In treatment, if for example, a patient, we discover that during pregnancy that she is pulmonary hypertension, but treatment naive, she is not on any treatment. I think here that according to the guideline class 2 AC, that initiating treatment should be considered, because sometimes the doctor will say, or some people said, oh, she's not on the treatment, let us to continue and then to start the treatment later on. No, I mean the guideline are according to, based on the result, that we find that yes, if she is naive, no harm, not no harm, it should be start on the treatment. In patients with history of aortic dissection, cesarean delivery should be considered from the beginning, because the risk is very high, as we said, because there is some physiological change during the labor itself. So this is very important. Beta blocker therapy through pregnancy should be considered in women with Marfan syndrome and other heritable thoracic aortic disease. This is very important, because the shearing force, because we are afraid from that the complication of this kind of disease because of the Marfan, as we know, and especially if they are dilated aorta, and we have to be careful. Induction of labor should be considered at 40-week gestation in all women with cardiac disease. This is something we should put it in mind. We have to take the decision. In patients with prepartum cardiomyopathy, there are new medication now, but we have to discuss it with the family, because it is not yet everybody familiar with the bromocriptine use, the drug using for prolactinemia. I mean, this is a new type of medication. And this is also something we consider also when treatment, because maybe consider to stop lactation and enhance recovery. This is very important. Pregnancy is not recommended in patient with vascular Ehlers-Danlos syndrome. Something we should be knowing about that. Breastfeeding is not recommended in a mother who take antiplatelet agent other than low-dose aspirin. This is, we have to understand this. Also, the new concept that, as I'm trying to try to summarize, that we have to know that modified WHO classification of mental risk is very important. Introduction of the pregnancy heart team, something we have to consider it. More attention to assist productive therapy and discussion, or as we said, prepartum cardiomyopathy is a new medication. This should be considered. Introduction of specific level of observation, and this is depend on the severity. And new information of the pharmacokinetic in pregnancy. More detailed information is depending on the animal, but we have to know that this is all animal experiment. Another important point is that cesarean section is to be discussed. The family should know from the beginning, based on the risk, and advise on contraception and determination of pregnancy in women with cardiac disease is now provided. This is very important. So essential message that we have to take care is risk estimation should be individualized. Indication for intervention, surgical or catheter, it can be taken, but it has to be also individualized. In women with moderate to high risk, we have to implement the modified WHO risk for class 2, 3, 2, and 4. And in women with congenital or other possibility of genetic heart disease, should offer fetal echocardiography in the week 19 and to 22 of pregnancy. And I think the next speaker or the speaker will give us more detail on that. And a delivery plan should be at the age, at the 20 or maximum 30 week, should be very clear from the beginning with the family and with the team. Induction of labor should be considered, as we said, don't wait more than 40 weeks. This is something should be there. Vaginal delivery is the first choice, as we are all, everybody won't try, but if not, you have to go to the other choice. And indication for cesarean section are, it is depending on the pathology and the severity of the disease. For example, severe pulmonary hypertension, this is for sure, it should be on a cesarean section. Pregnancy termination should be discussed if there is a high risk of maternal morbidity or mortality, and this is why we should follow the patient frequency, pregnancy, and the consequence fertility treat. This is once the patient delivers, the story is not finished, because many of them, they should not be allowed to have another pregnancy. So all patients with known cardiac or aortic disease need investigation and need observation clearly and during the pregnancy. And the following patient should be counseled against pregnancy. We have to know pulmonary hypertension, severe. Once we put severe, we have to know that this not allow for a pregnancy. Severe systemic ventricular dysfunction, severe coarctation, severe right ventricular or moderate severe decreased ventricular function. Once the severe is before the disease, we have to try to convince them not to get pregnancy. With severe arterial stenosis, even they are asymptomatic, because the term asymptomatic is very misleading, because sometimes they are asymptomatic because they are not doing the activity. Patient with severe aortic stenosis is the same. If left ventricle does not normalize in women with previous prepartum cardiomyopathy, they have to know they should not get a pregnancy. Women with mechanical valve, prosthetic valve also are very high, and low molecular weight heparin should only be used when weekly monitoring of factor 10. If you are not going to do weekly monitor, don't use low molecular weight heparin. Women with heart failure during pregnancy should be treated according to the current guideline for the non-pregnant. We are using the same medication. Of course, we have to know that ACE inhibitor or ARB, and this is our risky, contraindicated, and also after lactation for the baby. It is recommended to inform the woman with dilated cardiomyopathy and heart failure with reduced ejection fraction about the risk. This is something very important. In women, as we said, with prepartum cardiomyopathy and dilated cardiomyopathy, subsequent pregnancy is not recommended. Unfortunately, I have seen 3 or 4 of my patients, they have been saved from the previous pregnancy, but they are still, in spite of that, became pregnant. Prolonged QT interval syndrome also should be considered and categorized. Initiation of antihypertensive therapy treatment should be considered in all women with elevated blood pressure more than 150 and at values of more than 140 in women with gestational hypertension, pre-existing hypertension, and so here the level will go little bit in the patient who have previous history. Women at high risk, high or moderate risk of preeclampsia should be advised to take 100 to 150 milligram of acetyl salicylic acid from the week 12 to weeks 36 to 37. It has been proven by no doubt that aspirin is helpful. Methyl dopalapitirol and calcium antagonists are recommended for the treatment of hypertension. We have not to forget this. And low molecular weight is the agent of choice of for VT prophylaxis. And thrombolytic to treat thromboembolism should only be used in a patient with severe hypotensive shock, but also don't ignore if she is in shock, because as I told you, I have a very bad experience and there was a cardiac team and there were 2 hospitals involved, but the family was refusing and we lost the patient. In case of an emergency drug that are not recommended by the pharmaceutical industry during pregnancy and breastfeeding, they should not be withheld from the mother if we find that this is very crucial. So care during pregnancy, all women with congenital or other possible genetic disease, as we said, they should do fetal echo during pregnancy. Echocardiography is recommended for any pregnant patient with known cardiac problem, and a delivery plan should be ahead and should be known between the 20 to 30 week. I prefer to be from even the 20 weeks, and everybody was known and with anticoagulation is indicated. Low molecular weight heparin should only be used when weekly monitor, as we said this. So the delivery, we said that we should not wait for more than 40 weeks. Vaginal delivery is the best. Cesarean, we can do it. And endocarditis prophylaxis is not recommended. This is very important to put it in our mind. So working hard, but we have to work with the right tool. Thank you very much. Okay.
Dr. Aouda?
Yes, thank you, Sherif, for running the quick tour about pregnancy. You summarized it very well. It's much more complex than what you have explained, and I know you're doing an excellent job in this. Now it gives me a great pleasure introducing my my friend, partner, colleague, and for a long time, Dr. Sulaiman, who is the chief of pediatric cardiology in KidsHeart Abu Dhabi and in Al Ain and Dubai also, and he is an expert in the field of the fetal cardiology and pediatric cardiology, and he gives many courses in educating the environment in the our colleagues in the UAE. So he's going to give us a quick update on the fetal and cardiac screening or counseling parents with fetal heart disease. So without further delay, Dr. Sulaiman.
I don't know where to start, but thank you, Dr. Hussam, for the nice introduction, and I really appreciate that. Thank you to Dr. Bakir, who gave a great talk about how the pregnant lady with heart disease. It's very hard for me to follow Dr. Bakir up-to-date talk. However, in our talk today, we're just gonna talk how we're gonna talk to these parents who come to our office as a doctors. Either you are an OB doctor or neonatologist or pediatric cardiologist or fetal cardiologist, whatever your position, these parents will seek answer from everyone they know during the process of knowing that they have a child or a fetus with congenital heart disease. There will be a lot of anxiety involved in that. So our objective is just going to talk overview about fetal cardiology, counseling the parents. And then the most important part of really counseling these parents is to understand the congenital heart disease physiology and anatomy and the resources that you have around. Just to go quickly, I don't think I need to talk about the fetal circulation, but understanding the fetal circulation and the presence of the PDA and the sinus venosus as very very important part for us when we consult these patients, in addition to the PFO. So PDA, PFO, and sinus ductus venosus are very important component for perinatal circulation.
Sorry to interrupt. Can you put the slides on full screen so it's a little easier for everybody to?
Sure. Thank you.
Thank you.
So the perinatal diagnosis has gone through from the 70s until 2020, very much advanced. And now we can see even the face of the baby with the 4D, which is very nice picture to see and to show the parents. So in addition to genetic advancement, so we have gone through much. Now we are basically able to test the fetuses for any congenital or chromosomal anomalies before birth, and that will give a lot of knowledge about how we are going to handle these patients. So always we say we need to screen for congenital heart disease, and that's a simple reason, because it's the most common lethal congenital malformation. In addition to it's the most common congenital defect. So you have two major reasons for you to screen for it. And I believe our perinatologist college in perinatology, they always look at the heart as well as the rest of the body of the fetus. So there is three levels of fetal ultrasound. The first one will start with the OB technician. In addition, then level 2, which is usually fetal structural survey and 4-chamber view, usually done by radiologist or perinatologist. And the level 3 is done by fetal echocardiography, usually done by pediatric cardiologist as well as perinatologist. So the most important picture that we can see on this, what we call it 4-chamber view, as you see here, you have here the right ventricle, the right atrium, the left ventricle, and the left atrium. Theoretically, this is an easy picture to see. However, we still miss a lot of 4-chamber heart disease just because of the limitation of the training and the observation ability to see. If you add the outflow, you could basically, this is the outflow here. So this is the right ventricle here. This is the aorta here, the left ventricle and the aorta. And what we should see is what we call it crossing. So you see the pulmonary artery here, and you do not see the aorta and the pulmonary artery in the same parallel. So if one of them is a shortcut, the other one will be a long cut. In this one, we diagnose more serious congenital heart disease, including transposition, tetralogy, truncus, and interrupted aortic arch. I'm going to go through the indication. Basically, I don't need to talk about it much, but because I really want to emphasize on the counseling rather than talking about the indication. So there is maternal indication, there is fetal indication, and in addition to that, we have family indication that include congenital heart disease and chromosomal anomalies. But remember, in any time when we send the patient for fetal cardiology or to look at the heart specifically, most of these patients have no previous history, and at least more than 50% of them are newly diagnosed with fetal congenital heart disease. IVF is another indication for us to do fetal cardiology pictures. So how can we consult these parents? First of all, what question we need to answer? If you see things normal, so you say it is normal, but don't be overconfident. You have to talk about the limitation of the fetal echo, some small VSD, partial anomalies, and coarctation may not be seen clearly, and some detail of complex congenital also may not be seen clearly. So you have to tell the parents about the limitation of the echo and the expectation that things may change after beta a little bit, more or less. So if you see something abnormal, then you have to give a lot of time. You have to sit with the parents, you have to talk to them and explain to them what's that mean to them. And don't worry when you explain to them about the insurance impact. I have heard from a few of my colleagues that if I tell the insurance company, then they're not going to cover, they are not going to do this, and the parents is going to have a more problem and stuff like that. So I will say, whatever you see, you have to pass the message. It's not a good excuse for us just because the insurance will not cover that, we are gonna keep some information away from the patients. So surgery, you know, if you are worried about the surgical for the congenital heart disease, it's done in UAE, specifically in at least 2 centers, and it's almost free for any critical congenital heart disease. So be free to tell the parents that, yeah, we have surgery and it's available. And if you, you know, if you don't know what, where to refer the patient, what to do with them, feel free to ask any of your colleagues. If pediatric cardiology, they will be a good resource for you to advise. So what do we need to do the prenatal diagnosis? First of all, as we said, we need to reassure these parents and we need to counsel them. And we need to learn about the extent of these anomalies, therapeutic intervention, and plan for delivery. And most of all, we improve the postnatal outcome for these patients. So when we reassure this patient and we counsel them, so we need to educate them about the crucial planning for the fetus, and most important, that for them in the future, they will not have a surprise. I see many congenital heart disease after birth. The first question they will ask me, how come I did 5 ultrasound, nobody told me anything? And I really, at that time, I didn't know what to say to them. How can I explain to them the shortcoming, why we couldn't pick up this congenital anomaly? And there is so many reasons. This lecture really not going to talk about that. But this is a very important part of our counseling for the patient. So if you diagnose congenital heart disease and you tell them about it, they will have time to adjust. They will have a better plan. They will have, many of the people here in UAE, they are coming as an expat and they have a job that they have to fulfill. Coming with a baby with congenital heart disease is a major, major decision for them that may make them lose their life and their life in the UAE, and may have to leave the country for some reason. So if you decide that the patient have congenital heart disease and the patient may need congenital heart disease surgery after birth, we have at least 2 hospitals right now doing a critical congenital heart disease, include Sheikh Khalifa Medical Center and Al Jalila Hospital. Both of them have been really, really helpful for us to deal with a patient with congenital heart disease, even this with no insurance. So I will ask just a question, almost, you know, for us, which one is correct? Almost impossible to manage congenital heart disease in any NICU. Number 2, all congenital heart disease has to be delivered at surgical site center like THMC or Jalila Hospital or Gasmi Hospital. And number 3, congenital heart disease is more difficult to manage than managing patient with prematurity or pulmonary hypertension. So all of these 3 points are all not accurate. So congenital heart disease, if you are able to manage the patient and keep the prenatal circulation in the same way that was before the baby delivery, you most of the time will treat the patient very effectively. And just to let you know, none of the surgical center have a NICU. So patient delivered in any hospital, most of them unexpected, in Ras Al Khaimah or in Sharjah or in Dubai, and no one know about congenital heart disease, and the patient will be delivered in NICU. If they get diagnosed, then after that they get transferred to the proper hospital. The second thing, which one is not revealable out of this congenital heart disease? Hypoblast, tetralogy, truncus, total anomalies, tricuspid atresia. The answer is all of them repairable with varying degree of outcome, and we will talk about it later. So we'll start about hypoplastic left heart syndrome, one of the most difficult congenital heart disease when you tell the parents. Basically, as you see in this picture here, your left side of the heart is not there. So you basically have one pump, which is the right ventricle. This is a very serious heart disease. If this patient does not get diagnosed prenatally, then if we send them home, they will come back. As soon as the duct will close, this patient basically will die because they will not have enough ventricle, left ventricle outflow and blood circulation to the body. So this patient, if diagnosed prenatally, they will have a better outcome. They will be admitted to NICU. the first advice will tell you to start prostaglandin, basically to keep the PDA open. If the PDA open, then the body is going to circulate, get enough circulation through the PDA from the pulmonary bed, from the pulmonary artery to the PDA and to the aorta. Of course, you have to have the ASD open as well. And if it's not open, the patient will be very, very sick, as the pulmonary blood flow return, venous return will accumulate in the left ventricle and will cause severe pulmonary hypertension, and this is the most difficult patient to treat after birth. So hypoplastic left heart syndrome, theoretically treatable. We have the resources here in UAE. We can, initially the patient will be admitted to an ICU. You'll start the prostaglandin to keep the patient alive, and then you will start planning with a heart center, wherever you're going to send the patient. You're going to send them your report, and then they will do the first surgery in the first 2-3 weeks or whenever possible. Usually it will be done in the first month of life. The earlier, the better. So what is the first surgery for this patient? Basically, because the left side is not there. The patient have only right side of the heart. So, and the PDA, you cannot keep the patient on prostaglandin for life. So you will have to make your own new form of PDA. We call it, BT shunt. So it will do the same job like the PDA. However, you will be able to send the patient home with a BT shunt, and the patient will come back in a few months after that to have what we call it Glenn. So we will connect the SVC to the pulmonary artery, and that will take directly the blood coming from the SVC directly to the lung, get oxygenated, and come back to the left atrium, then to the right atrium, then the right ventricle, and then we'll go to the newly formed aorta. The newly formed aorta, we did it here in the first stage, which we call it Norwood. So hypoblast, Norwood BT shunt, Glenn. The last, this Glenn, usually we do it around 4 months or 4 to 6 months. And then the final surgery, we do what we call it Fontan. Basically, we connect the IVC and the SVC already connected from previous to the pulmonary artery. So all the blood return from the body will go directly to the lung, both to the right and the left of the lung. So the heart will only work for systemic circulation. Basically, you are unloading the heart from taking care of the blood that should go to the lung directly. The blood return to the lung will be passive because there is no more pump, and you only have this pump to the body. Hopefully, this will make the patient survive for a long period of time, for many years, 20 years, 25 years, and 30 years. There is some other complication this patient may have throughout their life. So patient with the hypoplastic left heart will be following with pediatric cardiology for all of his life. Usually the success for this patient depends on the institution, but it ranges between 70% maybe to 90% of the success for the first, second, and third operation. We don't call them repair, we call them palliation, because basically you still have the patient who has only one ventricle, and that's a big, big deal for life. So we'll talk about the next patient, assuming that we made the right diagnosis for him prenatally. And if we don't make the diagnosis prenatally and we make it postnatally, this is the physiology you need to understand of transposition of great arteries. You have basically the right atrium connected to the right ventricle, that's normal, but then the aorta connected to the right ventricle, and that's very much abnormal. And the other side, the left ventricle here to connected to the left atrium, left ventricle is connected right, but the left ventricle connected to the pulmonary artery, and that's absolutely a wrong way to go. So the blood with no oxygen will keep circulating in the body, and the blood will oxygen will keep circulating to the lung and go back to the left side of the heart. So this patient have to have a way of mixing, and usually the best way to mix is to have a good size atrial septal defect. So this patient, the way that we feel comfortable after birth, if we diagnose them, if they have a good atrial septal defect, that's an excellent patient, and you may not even need to start the prostaglandin. As you see here,
This is the PDA. Usually we start the prostaglandin automatically, hoping that it will help the patient at least temporary. However, if there is no good ASD, this patient will decompensate no matter how big is their PDA. For a simple reason, as you see here in this picture, the aortic pressure is, let's say, 80 millimeter mercury, and the pulmonary pressure will reflect the lung pressure, which may be 30 or 40. So the blood will always come from the aorta to the pulmonary artery, which means the not oxygenated will come to the pulmonary, and we're not going to get any benefit. What we need is the pulmonary artery blood, which is 99%, is to go through the PDA and subsequently go to the body, and then they give the patient the best chance of having a normal saturation. So patient with transposition of great arteries, they will need to have a good size ASD. In addition to start the prostaglandin, you may see it later if you think you don't need it in the future. This patient, usually they will have to have surgery in the first few weeks of life, the first week or 2 weeks or 3 weeks. But in general, this patient, they will not go home unless they have the surgery before going home. And the other thing, we need to do the surgery for them early because simple reason, if you keep the left ventricle without being exposed to the systemic circulation, the left ventricle will be weak, and subsequently the surgery will not succeed. As you see here, this is what we do during the surgery. So basically, you cut the aorta from this area, you cut the pulmonary from this area, and you basically put the pulmonary artery back where it belongs, and you put the aorta back where it belongs. The most difficult part of it is how to move the coronary artery from this side, as you see it here, to the new side for the coronary artery. That's what makes this surgery usually more difficult. So theoretically, after you fix and you switch, we call it arterial switch because you switch the arteries. After you switch, the patient should do very well throughout his life. There will be some complication related to that, especially stenotic of the pulmonary artery in here, in addition to some aortic regurgitation and dilation. This patient, again, they will be pediatric cardiology patient for life. They will never graduate. And this is the transposition of great artery. As you see here, we call it a big blue boy. The big because he's usually, the mom is a diabetic mom, and blue because he's have a transposition of great arteries, and boy because he's a boy. And usually the transposition is more common in boys. As you see here, this is in the intensive care. This is the saturation on the arms and the head, and this is the saturation in the leg. So it's reversed, where you should see the legs is more heavy because it's getting the blood from the pulmonary artery directly through the PDA. So if you see this picture, this is a transposition of great arteries. And I would like to thank one of my colleagues at American Hospital recently, who really diagnosed this patient with transposition of great arteries after birth, just because the patient have pre and post ductal, and he was able to call me in the morning, say, I didn't want to bother you, but I think this patient have transposition of great arteries. So I thank him enough. So there is sometimes simple thing we can do also postnatally to diagnose these patients. So going to tetralogy follow, the tetralogy follow, there is one single very important thing to understand, which is basically the pulmonary stenosis. So the tetralogy follow mainly depend on how bad is the pulmonary stenosis, but include other things such as the VSD, as you see it here, and include of the overriding of the aorta, but that's all gonna be just as a VSD if there is no pulmonary stenosis. So the patient outcome depend on the pulmonary stenosis. This patient may need surgery immediately after birth of the right ventricle outflow, basically obstructed much, and they may need the surgery between 4 to 6 months in most of the cases. So most of the cases, usually we will do surgery for them between 4 to 6 months. Usually this patient will not need a prostaglandin after birth unless the pulmonary artery and the pulmonary valve and the right ventricle outflow very much obstructed. Usually this patient, if they are much obstructed and they are not adequate to support the pulmonary circulation, then you will have to keep the PDA open until you decide about the surgery. The surgery, if it's early in infant, in the first month, usually will have a PT shunt, and then subsequently what we will do is a total repair, as you see it here. So you basically will close the VSD, you will put a patch in here in this area, you will open the pulmonary artery very wide open, and then you will allow the right ventricle outflow not to be obstructed. Of course, this patient, they will need another surgery down the road, maybe around 10 to 15 to 20 years old. But again, this patient, they will never graduate, and this patient will need a follow-up in general. But they will have overall a good life. They will be able to get married in the future. They will have kids. Same thing for transposition of great arteries as well. For hypoplastic, it's another talk. We cannot talk about it right now. So persistent Truncus arteriosus is another form of extreme severe congenital heart disease, where basically you don't have pulmonary artery and you don't have aorta. You only have one single trunk. You don't know what to call it. We call it truncus. So this is the truncal valve in here, and there is a large VSD here, and this valve that go through the truncal artery and then separate to the pulmonary arteries branches, and then the other one will make the aorta and the systemic circulation. This patient, initially, they will develop congestive heart failure. We diagnose many patients of this patient prenatally as well. If we diagnose them, we usually will confirm after birth. And this patient usually will need to have surgery in the first month or so. If you do not do surgery for them, they will develop severe pulmonary hypertension very short after 1 or 2 or 3 months. And then their repair will be very, very difficult. Initially, they will develop congestive heart failure of no repair done, but then they will be good because their pulmonary hypertension will develop. And then after that, will develop more cyanotic form of the congenital heart disease. So the way that we repair them, as you see, you have here a large VSD, you will close it, and you will assign the truncal valve only to be linked to the left ventricle. And then you will assign this conduit, which is the surgeon will connect between the right ventricle to the pulmonary artery directly. So because we don't have main pulmonary artery, this will be our new main pulmonary artery. Unfortunately, the conduit that we're going to place in here is going to be small and not enough for us to keep it for long period of time. And this patient will need the surgery either in the first few years, or maybe if we can keep him until after 10 years or so, to change the conduit and make it bigger conduit that can sustain him until adulthood. Tricuspid atresia, another form of congenital heart disease, where basically you don't have a tricuspid valve. Here it's blocked completely. That means you have a single ventricle. If you do not have a mitral valve or tricuspid valve, you are a single ventricle regardless of your name. So this patient also will need to go through palliative surgery, and will have at least, in the end of the day, they will have similar to what we talk about hypoblast. However, the outcome of this patient will be much better for a simple reason, because the ventricle they have is left ventricle. And this patient, if it's a woman, she has a good chance to get pregnant in the long term, of course, with high risk, but some of this patient can get pregnant and can have children as well. Coarctation of the aorta, as you see it here, one of the most difficult to diagnose prenatally. Basically, this patient, if they have a severe coarctation, they will need this duct to keep them alive until we repair them. And then after that, they can go home. Many of them go unrecognized because they are difficult to diagnose prenatally, and sometimes their saturation after birth will be normal, and they will go home. They will come back almost dead or in shock if the duct closed. So this patient, usually they need to fix their coarctation before going home, and then after that they may need some other intervention in the long term. This is the way that the surgeon will cut this area and this area and connect them to what we call it end-to-end repair. And this patient, again, they will not graduate. It's not in the end. It's not the end of it. This patient, they will need to follow with pediatric cardiology for almost all of their life. So remember one thing, that any patient for us, it's almost, they will follow with us for the rest of their life. After 18, they will probably follow with both adult and pediatric, or for adult with expertise in congenital heart disease. I'm just going to go through quickly of this, because usually it's easy to diagnose after birth, and this patient usually will not have a massive complication immediately after birth, including AF canal. Most of this patient, they will be repaired. The AF canal, as you see, there is no atrial septum primum, and there is large ventricle septum defect and the atrial septum defect. And this patient usually will repair them around 4 months of life or so. And sometimes we'll wait a little longer, or sometimes we'll do it a little early according to their situation. However, patient with Down syndrome, we usually repair them around 4 months to avoid the development of pulmonary hypertension. PSD, again, most of them will be repaired in the first few months of life. If you think this patient will develop congestive heart failure, they may be repaired early. And if you think they are okay, they can wait until 6 months to 8 months until they gain more weight. I just want to let our colleague in the OB in general, we do not take the weight of the patient as an exact, complete reason not to do any surgery. So currently, with our advancement, any patient can do surgery with starting from 2 kilo to 2.5 kilo. I believe our colleague in SKMC, as well as in Al Jalila, they will take children between 2.5 and 3 kilo to do a major surgery for them. PDN, ASD, most likely, this page, I only mention them because sometimes we don't mention them to patient before birth, because everybody will have an ASD before birth and everybody will have a BDA before birth. So we cannot tell them that, oh, you have a BDA and you will need to close it. This is part of the physiologic anatomic and nothing to be done for it. So if we give us, I think my time is still have a couple of minutes. So, what we will do, what we will find in our report, if we see this patient prenatally, you will find our recommendation about the mode of delivery. Most of the time we'll say it's a normal spontaneous vaginal delivery unless some other indication. And this patient, we will tell you if they need admission to the NICU or not. We'll tell you if they need oxygen or not. We'll tell you if they need prostaglandin or not. We'll tell you of the timing of the cardiology consult, if it's emergency or the next day. We'll tell you also if the patient will need a UAC and UVC line. And we'll tell you if the patient, from our own perspective, if the patient will need intubation. Most of the time, we'll like the patient not to have intubation. And we will tell you also about our expectation for the surgery and the timing for it as well. So the report from the fetal cardiologist not only will answer the question for you about the diagnosis of the fetal heart disease, but rather about the plan and how you can counsel the patient afterward. So take-home message, fetal echo is an essential for detecting congenital heart disease. Fetal echo improve outcome, and counseling patient is a very important for both the parents as well as our the neonatologist, and as for OBGYN and our perinatologist as well. So, and another important thing, you need to understand the resources for you, for the patient, and for the pediatric cardiology center as well. And thank you very much. This is the down road, what we expect to have. The more we detect, the more we will get adults with congenital heart disease. As you see in here in 2020, we have more adults with congenital heart disease because we are doing better job in detecting and treating congenital heart disease. Thank you very much.
Thank you, Dr. Sulaiman. And we'll start with the next session.
Thanks, Dr. Bakir and Dr. Sulaiman. Thank you so much for the wonderful presentations. From my side, it's my honor to present Prof. Lynn Simpson. She is a very well-known professor in obs and gynae in Columbia University. and she is the chief of the fetal and maternal medicine unit. Under her guidance, she has put together a fantastic team of starting from sonographers and midwives and clinicians offering her services in Colombia. She has a special interest in both the prenatal diagnosis of fetal heart disease, but also looking after women with heart disease, which gives a very rounded approach. Prof. Simpson, the floor to you.
So can you see my screen and hear me?
Yes, we
Yeah.
can. Yes, we can. Thank you.
All right, great. Well, thanks for that wonderful introduction. And I learned a lot at the last lecture, and it was just wonderful to hear about, how you counsel patients with specific defects and the management that you can anticipate after birth. But I'm going to really focus on the cardiac screening and how are we actually doing in picking up these anomalies prenatally. At least in the US, Dr. Charlie Kleinman has been considered kind of the father of fetal cardiology. He was a professor at Yale for a very long time before joining us at Columbia. But way back in the early 1980s, there was a publication from him suggesting that we should be able to diagnose upward of 90 to 95% of major heart defects prenatally. And that was, using the equipment of the day and the quality of ultrasound, as shown down here below. And I'm just going to go through kind of where we are today, and that we still aren't at that 95% prenatal detection rate that Dr. Kleinman challenged us to reach many years ago. So this is just a slide demonstrating the prenatal diagnosis of congenital heart disease globally. And this is demonstrating data from a number of different countries, 12 different countries actually, from Europe, North and South America, as well as Asia. And as you can see, the blue are the prenatally diagnosed cases and the red are the live births with congenital heart disease. And the vast majority of countries have more babies born with congenital heart disease than are detected prenatally. So we still, in the vast majority of countries around the world, are diagnosing less than half of all major heart defects before birth. And that was also confirmed in a recent meta-analysis of 7 different studies from Australia, Denmark, Spain, France, and the US, that with almost 5,000 cases, reported a detection rate prenatally of about 45%. So how are we doing here in the US? We always like to think here in the United States, we're doing a great job and detecting, congenital heart disease well before birth. But actually, when you look at the various studies that have been published out of the US, it doesn't really matter whether it's a population-based study out of a tertiary level center. The overall prenatal detection rate still is well below that kind of 90–95% threshold that we're trying to reach. And the one study I just wanted to point out, and this is a very large study of the Society of Thoracic Surgeons, who published on over 30,000 cases. And of those cases that they've managed, only about a third are diagnosed prenatally. So again, clearly well below the detection rate that we would like to reach. So what are we doing wrong? I think when we think of screening for any disease, you always have to go back to the principles of screening. It should be a serious disease, should have a high prevalence, there should be a simple and safe screening test, and detection should make a difference. So I think the first big question is congenital heart disease appropriate for screening? And I think, we heard about this a little bit in the last lecture. We know congenital heart disease is a big problem. It's responsible, for the majority of infant deaths, not only here in the US, but in many countries around the world. The prevalence at birth is about 8 per 1,000 live births. And about half of those are considered to be major. So, significant implications to the infant mortality and morbidity. And when we think about congenital heart disease at the time that we do our ultrasounds in the middle of pregnancy, the prevalence is about 10 per 1,000 pregnancies. So if you're doing a lot of prenatal screening, if you're an MFM or a radiologist or an OB-GYN who does ultrasound, probably 1% of your patients that you screen should have a heart defect detectable or present. And our goal is to detect all of those heart defects prenatally. And just in comparison to some of the other conditions that we do universal screening for, congenital heart disease is 6 times more common than trisomy 21 or Down syndrome, and 4 times more common than neural tube defects. So these are 2 conditions that we've developed, really strong, robust screening programs that detect, upward of 90% of cases prenatally. Yet we haven't been able to accomplish that in our prenatal screening programs for congenital heart disease. Now we are able to detect congenital heart disease prenatally, and again, this is from the Society of Thoracic Surgeons database. But the defects that we detect most commonly are those that affect the 4-chamber view. So hypoplastic left heart syndrome, hypoplastic right ventricle, a single ventricle, those are the defects we're more likely to see prenatally. When we get into the conal truncal abnormalities, tetralogy of Fallot, Truncus, and so on, the detection rate falls, maybe down to 30 to 50%. And then there's certain defects that we're really terrible at picking up prenatally, and that's our total anomalous pulmonary venous return, coarctation, small VSDs, and so on. So what are some of the benefits of prenatal diagnosis? And we heard these beautifully in the last lecture. By making that prenatal diagnosis, we know that gives us time for a full antenatal assessment. We can look for the associated chromosomal and syndromic and extracardiac malformations that may be associated with that heart defect. It also permits the multidisciplinary team to be involved, the perinatologist, the pediatric cardiologist, the CT surgeon, the geneticist, the neonatologist, so that the patient can really get a full understanding of what that heart condition is, how it will be managed, and what the outcome can be in terms of expectations. And then planning for that optimal obstetric and neonatal care. Certainly in our country, some patients, when a major heart defect is diagnosed early, they might decide not to continue that pregnancy. There might be a small subset of patients, like critical aortic stenosis, that may benefit from a fetal cardiac intervention. We do know that fetuses with congenital heart disease are at slightly higher risk of having fetal growth issues and being IUGR or growth restricted. So monitoring them for fetal growth and antenatal testing. And then probably most important is deciding, where should they deliver, what care is going to be required in the delivery room or shortly after birth to optimize their outcomes. And this is just some data, again, just demonstrating that a prenatal diagnosis can make a difference. This is comparing those that did not have a prenatal diagnosis compared to those that did. And it was clear in this particular study that was recently published in Pediatric Cardiology that those with a prenatal diagnosis had lower incidence of shock, needed less ventilatory support, and lower need for resuscitation. So that prenatal diagnosis does help with management right after birth. And there have been many studies that also demonstrate that a prenatal diagnosis, particularly for critical heart lesions like transmission of the great arteries with an intact interventricular septum, or a hypoplastic left heart with a restricted foramen or valley, cases that really require urgent intervention soon after birth, that a prenatal diagnosis can optimize their outcome and improve their survivability. And overall, that prenatal infants with a prenatal diagnosis are much less likely to die. So what is the issue? Like, why are we not picking up congenital heart disease better than we are? And I would argue, I think part of it is that we have 2 different approaches. When we screen for Down syndrome or we screen for neural tube defects, there's one approach for all patients that's used universally. But when we screen for congenital heart disease, we have 2 approaches. We use one approach for our low risk patients, and they get the standard ultrasound exam in the middle part of the pregnancy that includes the 4-chamber view, LVOT, RVOT, and then the 3-vessel trachea view if it's available, if you feasibly can get it. And then there's those patients that we identify to have increased risks for needing a fetal echocardiogram, as we heard in the last lecture. Maternal indications like diabetes, fetal indications, an extracardiac malformation. And those patients get sent for a fetal echocardiogram. So these are just the standard views that are required when we're doing a screening cardiac exam at the time of the anatomy scan. So again, it's your 4-chamber view, LVOT, RVOT, and your 3-vessel trachea view. And as we heard, the 4-chamber view overall can pick up somewhere between 40 to 50% of major heart defects. So again, it's not perfect, but it is a pretty good screening tool for identifying some heart abnormalities. By adding the ventricular outflow tracts, the overall pickup rate for congenital heart disease does increase. In the best of hands, it can get upward of 60 to 80% detection rate. And then the final view that's part of a standard cardiac screening exam is the 3-vessel trachea view. And studies suggest that the detection rate of congenital heart disease can then be increased somewhere up in the order of 80, 85%. And certainly the International Society of Ultrasound in Obstetrics and Gynecology now recommends, as does organizations in the United States, that the 3-vessel trachea view be included in your cardiac screening exam. Now, at least in the United States and many other countries as well, there are 2 approaches to screening for congenital heart disease at the time of an ultrasound exam before sending a patient on to a fetal echocardiogram. So we've just described what the standard examination is for our lowest risk patients: 4-chamber view, outflow tracts, and the 3-vessel trachea view if possible. But then there's those patients that are sent to the perinatologist because somebody thinks the heart might be abnormal, or they identify an omphalocele and there's a known association of congenital heart disease, or some other indication. And in this situation, at least in the US, we're required to do a detailed cardiac screen, which goes beyond the standard. It includes all of those standard images, but then we also need to confirm situs, get aortic arch, ductal arch images, images of the bicaval view, your superior and inferior vena cava, take a look at that interventricular septum closely to make sure there's not a VSD. And that 3-vessel view and 3-vessel trachea view are mandated as part of that detailed anatomy scan that we do for those patients at increased risk. And this is just demonstrating the axial sweep that we would do from our 4-chamber view up to our LVOT, RVOT, and those 2 additional views, the 3-vessel view and the 3-vessel trachea view, can then be obtained on your sweep as you go up towards the fetal head. And then this is just demonstrating those additional views that you want to obtain. And the easiest way to get those is just do your sagittal sweep from right to left, where you'll then pick up your bicaval view, your aortic arch view, and then your ductal view. So there has been some controversy, at least in the United States, whether this expanded cardiac views at the time of the detailed anatomy scan is worth the effort. And this was a study that was published out of California, where they actually looked at those patients that had these extra views done. And what they found was that it increased the length of the ultrasound examination by about 20%. It also increased the number of incomplete exams, so patients were having to come back for repeated ultrasounds. And yet it did not have a corresponding increase in the detection of congenital heart disease. 3% of the exams were abnormal with the basic protocol compared to 2% with this extended cardiac views. And there was no change in the referral for fetal echocardiography. So it leaves many of us wondering whether this expanded cardiac screening exam that we do is going to really increase the detection of congenital heart disease. So what about fetal echocardiography? What about adding all these additional views to our cardiac screening exam, or sending all patients to get a fetal echocardiogram? Is that going to result in the increased prenatal detection of congenital heart disease that we're hoping to achieve? As we know, there's many traditional risk factors for congenital heart disease. Many of them are listed here. And we know that these indications pick up somewhere around 20% of all congenital heart disease prenatally. When we look at the specific indications for sending a patient for a fetal echocardiogram, all the maternal indications, again, like lupus, IVF, exposure to certain teratogens, as well as all the fetal indications. They've had a prior first-degree relative, or you detect an abnormal fetal cardiac rate and rhythm, or you have a known chromosomal abnormality. We know of all of these indications, the one that performs the best is an abnormal cardiac screen. So someone doing that, standard examination on a low-risk patient, or even doing a detailed ultrasound on the higher risk patient, if someone thinks that the heart is abnormal, that is the indication that performs best at picking up congenital heart disease. But still, when you put all of these different indications together, it only identifies about 50% of all heart defects prenatally. So these are our current prenatal screening strategies for congenital heart disease that we've had over the years. Back in the 80s, early 90s, we started with just the 4-chamber view. It's supposed to pick up somewhere between 40 and 50% of congenital heart disease. In the 90s, we added the outflow tracks. And again, in the best of hands and experienced centers, should pick up somewhere between 60 and 80% of congenital heart disease. And now we've added the 3-vessel trachea view. And certainly most studies suggest somewhere up in the order of 75 to 80% of heart disease should be picked up by including that 3-vessel trachea view. We've just expanded the views for the detailed ultrasound examination. So we don't have a lot of information about how well this is going to perform. But if that last study that I just presented from out of California is any indication, it may not perform any better than what our previous screening exam performed. And then we have fetal echocardiography. If we do it just for traditional risk factors, picks up about 20%. Do it for indication-based, maternal and fetal, about 50%. And then if we did it on everyone, again, we don't have enough people that do fetal echocardiography to do this yet, but if we actually offered a fetal echocardiogram to all of our patients, studies suggest that we probably would be in that range that Dr. Kleinman suggested. Over 90% of major heart defects would be detected prenatally. And there was a recent study that was published out of China that actually looked at this in a prospective way, where they had over 10,000 low-risk patients undergo a fetal echocardiogram between 18 and 28 weeks. And overall, the sensitivity of that approach to pick up major congenital heart disease was 88%. So very, very near to that threshold number that Dr. Kleinman mentioned way back in the early 80s. So in conclusion, I think just when we look at where we've been, where we've gotten to, we're better, but we still aren't where we want to be. And I would argue that our current screening strategies really are still ineffective when you compare them to other screening programs that we have in obstetrics for other conditions that are just as significant, have morbidity and mortality issues for the neonate. Part of this is because the majority of congenital heart disease is in fact found in fetuses and neonates that have no identifiable risk factors. And currently, we only refer our patients for a fetal echocardiogram if we identify a risk factor. And I think that's where the limitation is. So in my opinion, there's 2 approaches we can take. In America, this is an approach that we're pushing in that we need to improve our imaging and maybe expand our views. And the reason I think this is being pushed here is that we just don't have enough people trained with expertise in fetal echocardiography. But if we really want to get up to a screening level, 90, 95%, as we have with our other screening programs, I actually think universal fetal echocardiography is really where we need to be if we really want to improve our overall detection of congenital heart disease. I'll probably be retired before this comes to be the standard, but I will not be surprised 20 years from now I look back and that's really what people are doing. Because if you consider all the expanded views that we're now being asked to do at the time of a detailed anatomy scan, we're getting very close to performing almost a screening fetal echocardiogram. So in conclusion, we still have some work to do. I think there's hope, but we're still not where we want to be. Thank you.
Thank you very much, Prof. Simpson, for the excellent presentation. It's pretty obvious. It always comes down to how many people look at the heart effectively. And this has always been the issue with cardiac screening. The next talk is from an excellent colleague from heading the fetal medicine part at Parkview Hospital. And so we'll pick up on a very specific issue in terms of looking at the fetal heart in the first trimester. Dubai and general UAE has the luxury to a certain degree to have a lot of fetal medicine consultants looking at first trimester scan and offering first trimester scan screening. So Anne will expand to possible signs that we can look at in the first trimester when looking for fetal cardiac disease. Anne, the floor is yours.
Well, thank you for this presentation, and I'm so honored to present my talk after such great experts. So here I'm going to talk about the early detection of congenital heart defects. So by early, I mean at the first trimester scan between 11 and 14 weeks of pregnancy. And this will be actually to help obstetricians to understand and navigate through all the screening tests that we can offer. So first of all, why early? So we've seen that in the previous talk, many cardiac defects are missed even in the best of hands. As we said, around 50% of cardiac defects are diagnosed during pregnancy in low-risk populations. It's also, highlighting the risk in the beginning of the pregnancy can improve the screening accuracy. It's helpful in a high BMI populations. Well, we've been through that before, but it also helps the parents to absorb the news and take time to prepare. More medically, it also explains sudden IUFD early in the pregnancy, and for doctors, well, it allows us to get a complete workup and invasive testing if the parents wish to have it. So what is the overall detection in the first trimester? So there are a few studies that have been published looking at the detection rate, and the rate goes from 2% very low to 50% in a study published in 2013. And then another systematic review got the same number at around like 43% of defect were diagnosed in the first trimester scan. So what are the tools that we have in the first trimester? Well, there are some indirect markers that you probably know, the nuchal translucency, the Dopplers, and then more direct signs of the cardiac anatomy. I will go through all the tools in detail. So the nuchal translucency, you all know that it was primarily put in place to diagnose more cases of Down syndrome, but it's actually a very strong risk factor for congenital heart defect. So in a low-risk population, the prevalence of cardiac anomalies at birth is roughly 0.5%. When there is a risk factor, it goes up to 2%, but if the nuchal translucency, it increased at 3.5 or above, the risk is actually more than 3%. So 3.5 millimeters is actually the 99 centiles and doesn't really vary with the size of the baby. And the thicker the nuchal translucency, the higher the risk of having a major defect, and in particular cardiac defects. So if you have a nuchal at around 3 millimeters, the risk would be 3%, but 4 to 5%, and above 5 or 6, it's up to 20% of babies that would have a cardiac defect. This is another study published a little bit later, but that basically shows the same numbers. You see that when you see the nuchal translucency increase, the risk of cardiac defect increases exponentially. And usually we consider the threshold of 3.5 millimeters as an indication for fetal echocardiogram. Here's a meta-analysis published a few years ago, and that shows the sensitivity and the specificity. So you see that the sensitivity is not that high, actually. It's around 20%, but the specificity is very high. So there are not so many false positive when the baby has an increased nuchal. So the second marker that we have in the first trimester is the Doppler of the ductus venosus. So if that's little, it's that little part that goes up from the umbilical vein. What is the positive predictive value of an abnormal DV in the first trimester? So if you look at fetuses with normal karyotype and normal nuchal translucency, so here's a study that has found that among 90 fetuses, they had 5 cases of congenital heart defect, which gives a positive predictive value of 5.5%. And 1 year later, a meta-analysis was published, and they actually concluded that in fetuses with a normal nuchal translucency, the sensitivity is quite low, and systematic fetal echo was actually considered as optional in this study. So here you can compare actually in this study the value of those markers. So here you have, when you have an increased nuchal above the 99th centile, you have approximately 27% detection of congenital heart defect at a cost of 1% of false positive. And if you have an abnormal ductus in the form of a reversed A wave, then you would pick up 39% of cardiac defect at a cost of 1.8% of false positive. I'll go now briefly to the tricuspid regurgitation. So the Doppler across the tricuspid valve in the first trimester. And again, this is the same team that compares the presence of tricuspid regurgitation. And actually, when there is a cardiac defect, 30% of babies roughly would have a tricuspid regurgitation early in the first trimester. And when there's no defect, the rate of regurgitation would be around 1%. But here you see at the last line that actually, yes, 50% of babies with a major defect will have either an abnormal Doppler and the ductus or tricuspid regurgitation or an abnormal nuchal, but also 8% of normal babies. So it's a high false positive rate, unfortunately. So here again, there was a meta-analysis published regarding the diagnostic accuracy of tricuspid regurgitation. And again, the conclusion was that there are no firm recommendations to refer for cardiac ultrasound in the presence of an isolated tricuspid regurgitation in the first trimester. So now we move on to more specific views, so the direct cardiac views in the first trimester. So here you have the cardiac axis. You all know that the heart is supposed to be to the left side with an angle of 45 degrees, more or less. And here in this study, it has been shown that actually if there was an abnormal cardiac axis that was either less than 30% or more than 60%, it would help detecting 80% of babies with a cardiac defect. So that completely outperforms the presence of markers like an increased nuchal or abnormal Doppler. Now another specific view, which is the three-vessel view that we can also see in the second trimester, but it's also a V sign that you can detect with color Doppler in the first trimester. And here is another study that is a little bit similar, that also shows that if you combine either an abnormal nuchal, an abnormal three-vessel view, or an abnormal axis, you can detect up to 90% of babies with Down syndrome, but at the cost of a quite high false positive rate for referral for fetal echo. And now finally, the last view that you can try and obtain in the first trimester is the actual full chamber view, black and white and Doppler. And again, it's a very detailed study that was published, and that shows that if you look at the 4-chamber view and the 3-vessel view, and that either of those view is abnormal, you could detect up to 88% of babies with cardiac anomaly, when the nuchal translucency above 3.5 millimeter will only pick up 37% of the cases. So now what can we actually achieve in a routine first trimester scan using all those views? So here is a study that used the protocol of having a 4-chamber view, color and black and white, the outflow tract, and also the Doppler of the tricuspid valve, the ductus venosus, and obviously the nuchal translucency with a reflex cardiac echo very early in pregnancy, 11 to 13 weeks, if any abnormality of the 4-chamber or 3 vessels view was detected, or if the nuchal was above 99%, and if the nuchal was borderline, or if there was an anomaly in the Doppler, the patients had the fetal echo later in pregnancy. More than 90% of the scan were actually performed in the 12 and 13 weeks, so not so early as 11 weeks. So here are all the defects that they were able to diagnose at each stage of the pregnancy. Of note, they also, all patients also had a detailed anatomy scan in the 3rd trimester. I have summarized the findings here. So in the 1st trimester, they diagnosed all cases of tricuspid and pulmonary atresia, and more than 90% of the case of hypoplastic left heart syndrome and AVSD. Of course, it's a research setting. And here's a breakdown of their findings. So in the 1st trimester, with this very specific protocol, they could detect 30% of anomalies, and 50% were later diagnosed in the 2nd trimester. And then the later anomaly scan also detected 12%, and postnatally, you had only 3.6% of babies that were missed. Using the same cohort, they have actually tried to show which factor was related with the defect. So here again, you see that in patients in babies with major cardiac defect, you had an increased nuchal and abnormal Doppler in 1/4 to 1/3 of babies, but those signs could also be present in babies with no defect at a lower rate. And so globally, in chromosomally normal fetuses, there was an abnormal Doppler or nuchal in roughly half of the babies, and that had a heart defect, and 4% in those without a heart defect. But unfortunately, they were not really able to define what was the contribution of each marker in the detection of those defects. So here is an interesting study that tried to understand what was related with an increased detection of cardiac defect early in pregnancy. And actually, the striking finding was that the use of a protocol for screening, a detailed protocol for screening, was actually the main factor. So what is the protocol? So in the 1st trimester, what is required by the International Society of Ultrasound, which gives an outline of the screening that we should be performing, is actually only to document a regular cardiac activity in the fetus. Now, very recently, the American Institute for Ultrasound in Medicine has published what is actually required in a detailed fetus scan in the 12 and 13 weeks of pregnancy. So, first of all, they state that a detailed 1st trimester scan may be performed when you had one of those risk factors, which could be 1st degree with a cardiac defect, but also advanced maternal age, increased BMI, etc. But they also state that there is this guideline is not intended to establish a legal standard of care. So it can be offered to the patient, but it doesn't, you don't have to. So here are what they suggest. So you can see that what is required is what basically the sign that I've explained before. So you have the 4-chamber view with color and without color, the 3-vessel trachea view. Now, if you suspect an anomaly of the patient is very high risk, you can also offer Doppler and the sagittal views of the heart. So now what should we be doing between documenting cardiac activity and having a very detailed first trimester assessment of the fetal heart? So actually, our ESOC expert, even if the guideline has not been published yet, consider that it would be ideal to obtain a 4-chamber view and a 3-vessel trachea view in each and every patient in the first trimester, just with those 2 sections. Another ESOC expert also considered that, to be practical, in every single patient, we should be performing a transabdominal scan with a 4-chamber view and a 3-vessel trachea view. And in more high-risk case or patients with high BMI or in very small fetuses, we could offer a transvaginal scan to get better images. So now, is it feasible? So here is an interesting study that has tried and obtained 4-chamber views and 3-vessel trachea view in all fetuses during the routine first trimester scan. They could go either transabdominal or transvaginal. And you can see that the success rate was roughly 80%. In 20% of the case, it was either not optimal or not feasible. So because of limitations, so I will go quickly through all the limitations that can be technical or medical, and also the drawback of false positive. So technical, of course, the heart is extremely small in the beginning of the pregnancy and grows much in the second trimester. And the detection rate of any kind of anomaly during the first trimester scan is actually very different at 11 weeks than it is at 14 weeks. Now, it's a very nice study here that shows the detection rate of cardiac structures. Well, the visual, not the detection, but the ability to obtain the cardiac structures by scan, depending on the number of weeks, the use of transvaginal or transabdominal ultrasound and black and white or color Doppler. You can see that at 11 weeks, if you only use transabdominal B mode, there are absolutely no chance they could get any cardiac structure view. And if you would do the same scan at 13 weeks using TV and TA ultrasound with and without color Doppler, you could go up to 88% of scans that were successful. Now, also the natural progression of the disease. Of course, there are some structures that are extremely small in the first trimester, some disease that will only show later in pregnancy, like tumors, heart block, cardiomyopathies, and late progression of some defect like the semilunar valve, the arches anomaly. And yeah, here is the concordance and the rate of false positive when we're using a strict protocol for screening. So here's a review that was published in 2014. So it's about fetal echocardiogram, not basic screening, but when they compared an early fetal echo and a follow-up echo in the mid-trimester, the concordance between the findings was 75%. Another study that is a little bit similar, that among 1,200 fetuses that had a fetal echo in the first trimester and then another one 6 weeks later, you can see that in 46 cases, the same anomaly was later diagnosed. In 57, actually no anomalies was later diagnosed, but to be fair, it was mostly when it was only indirect markers like abnormal Dopplers. And in 29 cases, there was a new finding or progression of the anomaly. And just to, I'm repeating myself, but you can have either an abnormal nuchal cardiac axis or abnormal 3-vessel view in up to 12% of babies without a cardiac defect. And same, you can have an increased nuchal or abnormal Dopplers in up to 8% of babies without a cardiac defect. So when should we be referring to the fetal cardiologist? So ideally, well, all fetuses with any kind of markers like Doppler anomaly, increased nuchal should have an early fetal echo. Now, referral varies according to center and resources and also insurance coverage. But there is a common agreement is that all fetuses with an increased nuchal above the 99th centile should have a fetal echocardiogram. Now, the age at which it's performed depends on the center. Some cardiologists feel more comfortable at 14 to 16 weeks, or when some feel more comfortable after 20 weeks. Now, what about the nuchal when they are borderline or abnormal Doppler? Well, actually, many centers still consider that a detailed assessment at 20 weeks is sufficient. As I've said, this would apply to 8% of pregnancies, which would detect 50% of anomalies. Now, if direct views are suspicious, what should we do? Offer another fetal echo immediately or 16, 18 weeks? Again, this would apply to 12% of patients in this case. So in summary, an early detection is beneficial for parents and for doctors, and detection of cardiac defect is very difficult, even in the best of hand, and especially in a high BMI population. So again, I've said that prenatal detection through standard screening without counting the first trimester scan is around 50% in the low risk population. And it's the same study that showed that the first trimester scan actually had this potential to improve the detection of cardiac defect. So ideally, all scans should include all those views and all those markers with a reflex referral for fetal echo. Now, of course, there is a high false positive rate, and practically, well, each center needs to define its protocol and indication for fetal echo, either as a center or individually for each patient. Thank you.
Thank you, Anne, for the fantastic talk. I will be devil's advocate here and question the part, do we actually improve outcome by detecting things in the first trimester? Because we are raising suspicion rather than setting a diagnosis, and we are subjecting our patients to 2 to 3 weeks possibly of anxiety without changing the final outcome. So I would love to take your view and probably Lynn's view on that. What do you really see as the main advantage of raising the worry in the first trimester that there might be a problem? How are you going to change your management?
Well, I totally agree. It causes anxiety. Now, I think it also depends on the way you present things to parents. I think if you tell them it's actually, they can take it as a chance of having a better screening, that now that they've been identified as a high-risk pregnancy, and they can be referred to for a fetal echo, it's actually a chance to have a very good screening. But I agree. Actually, some parents will not really take the news very well, and this can cause a lot of anxiety in couples. Yeah, it also allows patients to maybe have invasive testing early in pregnancy rather than having this diagnosis done at 22 weeks when, you know, options are more limited. So yeah, I think it has a lot of drawbacks because yes, there are a lot of false positives, but yeah, it can be also seen as a chance to have, you know, a final diagnosis and not miss it.
I think for us, at least, those early cardiac evaluations, you know, at the 12 to 14 week mark, for the most part, we reserve those to patients at risk. So they've either had a prior affected pregnancy or they're in a really high risk group and they might have a big NT. But it's primarily used in our practice for reassurance, because again, the vast majority are still going to be normal, particularly if it's a history of a prior affected child. And so the early cardiac screen, I think, is often early reassurance at the 4-chamber view and the 3-vessel trachea view, and things look to be developing normally. So they actually kind of breathe easier until they have their standard echo in the 2nd trimester. I don't think, at least in the US, we're going to go to doing, a full fetal echocardiogram in the 1st trimester. And I do think we don't have the resources to do it in the 2nd trimester for everyone. So I just don't think we're headed there in the 1st trimester. But, there is a subset of patients where I think it is valuable to take a look.
Thank you so much. If I may, Dr. Sulaiman, I've posted in the panelist part a question, if I may ask both adult cardiologists and especially our colleagues from New York. We do live and going through COVID wave of maternal infections, and we do have a number of our mothers in hospitals and potentially in ICU. Now, we know that COVID has major implication in cardiac function with great potential in causing cardiac myocardial damage. So I would like to get your experience, your suggestions. Obstetricians, sometimes we focused in one part and we on occasions miss the kind of the rest of the patient and patient's health. So what is your experience both on the follow-up, on the acute case, and also on the recovery of our moms that had a severe infection at 30 weeks, they recovered, and they follow on supposedly normal?
Well, we are in our center. We do see patients who are pregnant and they come for a cardiac evaluation, and we have seen some of them, especially worrying about the COVID, and we reassured them that, for example, in our center, we almost have 100% vaccination program for all our staff. So in safety perspective, we feel that we provide maximum safety to them. Now, in concern to the risk of infection for them, we actually, it's a difficult question. I mean, we saw some complication from cardiac standpoint, including chronic dyspnea, like that extend more than 3-4 months post-COVID. And luckily, these are not pregnant ladies, or none of them has been pregnant in my experience. We saw a couple patients with pericardial effusion, and we are following these patients. And actually, as it's an evolving field during the COVID time now. So I would say that in general, I have a limited experience. We saw few of the chronic dyspnea, and we saw a couple cases of pericardial effusion.
If you allow me just to interfere, I mean, as Dr. Oda said, that it's very difficult to give experience because there is very limited cases we saw was pregnant. But theoretically, I think the problem of pregnancy is the hypercoagulopathy. And we expect that if a pregnant lady was develop COVID or something like that, I mean, the problem of hypercoagulopathy will be there, especially if they are having mitral valve replacements, or so maybe we have to be careful about that. But to be honest, we have no experience in this, but this theoretical.
Well, certainly in New York, early in the pandemic, last February, March, April, May, I think New York was hit pretty hard, and we reported on our first, I think, 200 pregnant women with COVID. And I guess the reassuring part is that the vast majority of pregnant women did well. All of the babies did well. we did have a handful in New York. This was a multi-center with different tertiary care centers in Manhattan participating, but so there were a handful of women that were intubated in ICUs, but the vast majority did not require that degree of care, and people did well. So we don't know long-term, there certainly are some people, including one of my own personal patients who has had issues, 6 months after COVID and delivering, where she still is exhausted, has shortness of breath, and is still symptomatic. But the vast majority in our experience actually do very well.
Thank you. Thank you all.
As a matter of fact, we last webinar, we have a talk about pregnant ladies during pregnancy, and the speaker was from NYP, from New York. And the conclusion was they are not as much higher, just like Dr. Simpson stated, than other part of the population. And I believe recently they have added to them that they are okay to get also vaccination as well. Is everybody understanding this fact as it is?
Well, the recommendations are that it comes down to personal choice until more data is available on the safety part of the vaccines, and most big companies are pushing on research on pregnancy. There's, at least the way that I understand it, there's no, from the way that the vaccines that are in the market work, there's no reason to believe that there would be an adverse effect to pregnancy and fetus. But as with everything, you need some strong data to support it. My worry with pregnancy, I kind of disagree with you, Sulaiman, because the impression is that pregnant women actually do worse with COVID, especially in the third trimester. And there is some data coming through that they're more likely to have serious complication. My slight fear is that we may, well, hopefully we'll see how the data come. A lot of these young women will go through with myocardial damage, with that may go undetected initially because they're young and healthy otherwise, and they will go through. So it's going to be interesting to see from the big studies and the big centers what is the outcome with the cardiac function of these mothers.
Okay. Any other person who would like to have any question?
I think there was one question from one of the participants. Not sure if we answered that, from Dr. Kalapana. Are you able to see that from the Q&A?
Yeah, let me just comment. And I think Dr. George has answered on the panel on the side question and answer. But let me, there was one question asking about universal screening. Why don't we do universal screening? And I think Dr. Simpson already kind of mentioned that, and we all agree. And Dr. George Michaelidis also stated the same thing. We probably don't have the way and the mean to do it. I will just comment in why we are still behind on detection. I think we are doing the universal screening in the matter of insurance payment, in the matter of assigning a specific detailed screening for the patient at first trimester, second trimester, and third trimester. The problem, I think, comes with the expertise that involved during this screening. In addition to the expertise, we have variable people who's doing things. Like we have the radiologist who's doing, we have some OB who's doing, we have pediatric cardiology and perinatologist. And a lot of time, with the restriction of hospital regulation, they push as an example patient to have a radiology evaluation. And some of these radiologists may be adequate, some of them not trained enough. The other thing I have learned through this many years that we have been working in UAE, the equipment, the technology is not available for everyone. you'll be surprised, you'll find some centers that they still have still pictures to decide about congenital heart disease or so, fetal congenital heart disease or so. So having technology and having resources is a very difficult, and then you have the personnel, you know, the technician who's involved in the screening and the other people who's reading as well. When I came to UAE, we established a program in Tawam Hospital, and that program was aimed at detecting fetal congenital heart disease. So I was included in it, and my partner, Dr. Hamdan, published actually a paper about it. And initially, the detection rate before that program was established, you know, it was about 30% to the patient who came to us in the hospital. With time, we improved to the point we reached to detect about 90 to 92%, which is, you know, like the highest standard you could imagine. So, but this is a selected program, very hard to apply it to a general population programs.
Yeah, at Columbia, we have the same experience. You know, we do multiple cardiac views at the time of our anatomy scan, and it's pretty rare that we miss a major heart defect. Certainly, we're well over 95% detection rate with that approach. But again, it's not, if you look at, you know, very resourceful, you know, people have the best of equipment and a lot of experience, spending a lot of time looking at hearts, they're going to perform well. But as you say, screening is done many different ways across the world, and I think that's part of the issue.
Any other question from any of the, any other comment? Dr. Michaelides?
Not for me, thank you so much.
I want to make it sure you're still with us. All right, so if we are done, I would just like to thank you everyone for participating in this webinar. Every time I am doing a webinar, I say next time this is going to be my last. By the time I finish the webinar, I'm already thinking about the next one. So I think we will do another one, hopefully in the near future, another 1 month or two, and we will have some more topic, inshallah. If any one of you have any suggestion for our next webinar, you know, we'll be very happy to take that suggestion and, you know, apply some specific topics to the webinar.
Dr. Sulaiman, just a general announcement, because after the webinar, we usually get a lot of questions about the CME, and I think that your center is probably doing that. It just, I request just patience for a few days until we get all the data and the information, and we'll be more than happy to send it. I think Dr. Sulaiman and his team is working on that.
Absolutely, we will get, as soon as we get the people who attended, we will send it within a few days. As you know, there is many people, and then it all need to be designed, their name written. So it will take a few days, but for sure you will get it. If you don't get it, just please send an email to see me at kidsheart.ae, and we will respond to that email and we'll send you your certificate.
Thank you.
Thank you very much. Thank you to all.
All right, bye-bye.
Thanks everybody,
Good
lovely
night.
talks.
Good night.
Thank you.
Good night.
Bye.
Good night, everyone.
Bye-bye.